Ciao mondo, hello world, hola mundo, hello mom. We're here today in Vicenza taking a cappuccino with you and discussing about a new term used in literature, renal angina. We're going to have a debate in our Vicenza course in June this year with Ming Chawla discussing the term as a new concept and a perfect term to describe a condition of increased risk of acute kidney injury without meeting the criteria for the diagnosis with an increase of creatinine of 0.3 milligram per deciliter. So if there is a slight movement of creatinine below 0.3, or there is oliguria, or there is a condition of high risk, renal angina may actually identify a group of population that are highly at risk of AKI. And in fact, in a study we published recently, we were able to show that those people who are identifiable under the term renal angina have worse outcome and higher probability to develop mild to severe AKI. On the other side, Paul Palevsky from Pittsburgh will debate, as he already did in JSON, the concept that it is probably not a right concept and definitely this is the wrong term. He says that the concept might be, but the term definitely does not describe what angina is typically for, which is a condition in which ischemic myocardium may actually lead to chest pain and finally to an acute coronary syndrome. In this case, we're not going to have an acute ischemic syndrome of the kidney. In fact, you may have high risk in conditions of toxic AKI, in condition of severe surgical procedures, or other conditions that not necessarily describe an ischemic condition in the kidney. For this reason, Paul Palevsky suggests that the renal angina is a wrong term and should not be used to describe this type of patients. I am actually in the middle, and I think that the term angina perfectly somehow reconciles the similarity between the acute coronary syndrome and the risk for AKI and the AKI itself. In some patients, you have chest pain, you diagnose acute myocardial infarction when an ST elevation is detected in the AKG. But if there is no ST elevation, you can actually diagnose an acute coronary syndrome using troponin. And in this case, you define this as a non-ST elevation myocardial infarction. For AKI, we suppose is exactly the same thing. If you have a creatinine increase, you can actually diagnose AKI according to creatinine criteria. But in some cases, creatinine does not move, but still you have an increase in damaged biomarkers like TIM2 or IGF-BP7, what today is called NephroCheck. This allows you the possibility to define AKI as a preclinical or subclinical, the equivalent of no ST elevation myocardial infarction. So I think that the term angina may or may not be adequate depending on what people actually intend for. And I invite all of you to join the debate at our International Vicenza course in June 9 to 12 on critical care nephrology. It will be very nice to see these two giants of critical care nephrology debating this topic, and I will be the chairman. With this, I thank you very much for joining today's Cappuccino, and I wish you a wonderful day.